Hi, good evening. Thank you, Dr. Stevens, for the introduction. Again, my name is Bossakara Sokhom, and I am currently a pain fellow here at Stanford. I have a few months left before I move on to my next opportunity. Um, Thank you for spending part of your evening with us to learn more about migraine. I know that many of you either suffer from migraine yourself or know someone who has migraine. Thus, this evening, I hope to provide you an overview of chronic migraine in the adult population. I would also like to note that I intentionally do not use the word migraine headache because there are patients who suffer from migraines who do not have headache. We will discuss this later in our presentation. During this presentation, my goal is to answer these three main questions and go over some of the treatment options that we offer here at the Stanford Pain Clinic, which I believe that many of you agree are the most relevant take-home points for our presentation tonight. At the end of the presentations, I will attempt to answer some of your questions. If at the end of the presentation you still have questions, please forward your questions to one of our coordinators, and I'm happy to answer your questions. Otherwise, I encourage you to ask your medical provider any questions that you have, as you are an important part of your treatment team. So the objectives again is to answer what is migraine, definitions and epidemiology, which we'll go over, pathophysiology, which is mainly the cause and the mechanisms. What are some of the triggers and some of the subtypes of migraines, and what are some of the potential complications? And then we'll go ahead with the treatment of migraines. And the main focus is on both the acute treatment and also the preventive treatments. And again, treatment options at our Stanford Pain Clinic. So the question is, what is migraines? I'm trying to show that migraine has been there for quite a while. Even the Greek has a word for it, and then it's translated to lung, and then the French. Migraine is a common cause of disability and loss of work. It is, in fact, the second leading cause of neurological disability after tension headache. It should be noted that in recent years, it has become apparent that many patients who suffer symptoms from migraine do not have severe headache as a dominant symptom. Some of the primary complaints include vertigo or dizziness, ear pain, ear or head fullness, sinus pressure, intermittent hearing loss, or eye pain. We will go over why this is the case in a few slides. So again, the definition of migraines, it is generally defined as genetically influenced complex neurological disorder characterized by episodes of moderate to severe headache, typically unilateral, which is one-sided, and frequently accompanied by nausea and heightened sensitivity to light and sound, which we call photophobia or phonophobia, can last hours to days and significantly impact daily activities and, of course, quality of life. It's quite prevalent. It's about 12% of the populations experience migraine. It's commonly occur in our female population, so it's up to 17% among women and 6% among men. It increases during puberty and peaks between the ages of 35 and 39 and decreases later in life after menopause. It's again the second leading cause of disability globally. It tends to run in families, hence the genetic components. 40% risk of developing migraine if one of your parents has a history of migraine. And if both of your parents have a history of migraine, the risk could go up to 75%. So there is a high genetic component to it. Which is related to vessels. but it is no longer an acceptable theory, given our recent understandings. Recently, there are identification of new migraine-associated genes, discovery of nerves that are potential target for treatments, and recognition of brain regions that's involved during migraine attacks, and proteins in the brains that are also involved. So if you look here on this slide, the right side, the figure on the right side, there's components of the brain regions, the spinal cords, the nerves, and how some people develop pains that's not really just in the head, but from the neck can go up or down. And again, the brain involved is quite varied to include the cortex, the thalamus, the hypothalamus, and the proteins and the nerves, the different nerve systems, which we'll dig a bit deeper later. And this is just another presentations of the complexity of migraine. So for those who like spaghetti and meatball, here's the diagram with the lines and circles showing the complex mechanism of migraine, or if you will, the messiness of it all. For some of you in our audience tonight, you might recognize the role of spinopalatin ganglion, which is symbolized by the letters SPG in the middle of our screens. Spinopalatin ganglion is basically a bundle of nerve behind your nose. We sometimes block these ganglions by spraying numbing medications deep into the nose to use as both a diagnostic and therapeutic option for migraine. So again, migraine is not just about blood vessels in your brain. It's about the nerves and other proteins that's involved also. And what are some of the triggers of migraines? So there's a study that found that 76% of patients reported having triggers that leads to their migraine episodes. It is important to keep in mind that some triggers are probable contributors, while others are possible, and some are not proven. Based on our current understanding. But again, these triggers vary amongst different people. Some of the factors include stress, that some studies found that it could affect 80% of the case. It is a probable factor um, of migraines. Hormonal changes in about 65% of cases during menstruations, ovulation, and pregnancy. So during the perimenstrual period, some people feels that they have more migraines than other periods, just because the hormonal changes itself. There's people who skip meals. 50% of patients reported that as a probable cause or probable factor that leads to migraines. And weather changes affecting 53% of individuals. You also have some people that's not having enough sleep or having too much sleep that can affect the the cause of migraine. And here we have odors. So some people are more sensitive to perfume um, or other petroleum based products than others. And some people report having neck pains as a trigger of their migraine, about 38% of cases. Definitely exposure to light, alcohol ingestions. The many studies finds that for alcohol, mainly it's wine as a probable factor, and also smoking in 36% of the patients who reported that is one of their cause of migraines. Uh, Being in a warm weather, like being too hot, um, food in some cases, mainly it's the aspartame that is a possible factor, and also tyramines and chocolates, but those two are unproven factors thus far. And also exercises. Some people reports that whenever they go to the gyms, engage with physical activities in a high intensity settings that can trigger their migraines. And 5% of the study populations reported sexual activity as a cause or a trigger of their migraines. Given what is just listed, you probably agree that causes and triggers of migraines are complex. As you can see in this figure on the right, there is involvement of genes, the environment, and also personal factors such as one's metabolism, hormones, and the medications that we take every day. All of these combine to affect our brain, which then release proteins and other chemicals that cause migraine attacks. And we'll go over some of it later in our presentation. So what are some of the common types of migraines? There are different subtypes of migraines, and here are some of the most common subtypes. We have migraine without aura. Um, Again, this is a recurrent headache that lasts about 4 to 72 hours, so 4 hours to about 3 days. Again, typically one-sided, can be pulsating, moderate to severe, and can be worsened with physical activities and associated with nausea, light, and sound. So migraine without aura is actually the most common subtypes. It's accounted for 75% of migraine. And then we have migraine with aura, which is again, recurrence, fully reversible attacks, lasting minutes only, and typically presents with one or more one-sided symptoms. Either it's visual related or it's sensory related. Sometimes it could be speech and language and motor, etc. Followed by headache and other migraine symptoms. The third most common type is the chronic migraines. It's the definition of chronic migraine is defined as headache that occurs on 15 or more days in a month, so over the span of 30 days, and it occurs for more than 3 months. That's the chronic part of it. Um, and patients with chronic migraines tend to have migraine features that present on at least 8 or more days in a month. Again, on the right, this figure shows the complexity of migraines. I feel like I don't mention enough the word complex and complexities when talking about migraines, because again, it's really a difficult condition to have, to describe, and also to treat. And one study found about 180 genetic variation that contribute to our, what we can call it, bread and butter migraine versus other migraines that we talk about. That's also listed here on the right, which is the familial hemiplegic migraines, which is a migraine that also involves some type of legs or arm paralysis, and that is just one gene that's involved. Um, and here, another subtype of migraines that we should mention is called episodic syndromes that may associated with migraines, tends to have uh, other organ system involvement. For instance, recurrent gastrointestinal disturbances that can be stomach ache, discomfort, nausea, and vomiting. And some have bouts of dizziness, while others have balance issues that led them to need to tilt their head to one side or the other to help control their symptoms. We're going to talk about some of the potential complications of migraines. Um, Again, for migraines that's not controlled or treated, patients tend to have debilitating attack that lasts for more than 3 days. You have persistent aura with no brain infarction or no blockage in the brain or no imaging that's on the brain that's found during the the migraine attacks, or stroke-like symptoms with imaging findings. So one or more oral symptoms that are associated with stroke-like finding on brain imaging during atypical migraine attacks. And of course, another potential complication is migraine-triggered seizure. That is like a seizure that occurs during attack of migraine with aura. So earlier, we went over some of the causes, the triggers, and subtypes and potential complications of migraine. Now we will look at migraine treatment. It must be noted that there is no high quality research that's supporting the different factors that likely cause or play a role in migraine, but there is substantial work that's put into studying the mechanism of migraines and finding potential targets for the treatment of it. Um, Thus, migraine treatment focuses on these three pillars, which we will go over in more details. So one of the pillars is the non-pharmaceutical management. The other one is the acute treatment, and then the preventive treatment. And if you look on the slide on the right again, this is showing a figure that we've seen before. And I boxed in red the potential target for treatment. So you have some uh, potential target for treatment in the brain, like in the cortex and in the thalamus. Um, for those areas, most of the time it's based on neuromodulation. And then lower down the figure for the upper cervical nerves that you also have target for local injections and neuromodulations. So local injections, which means that we use needle and syringe loaded with medications, could be numbing medications, could be Botox, could be steroids that we inject locally close to the nerves that could potentially cause migraine. And on the top right, CGRP is one of the proteins that we'll go over all of this later, but I just want to provide an overview of the potential targets for treatments. So there's target for the small molecules and also their receptors. And the last um, box on the bottom right is the trigeminal cervical complex. That could be another target for medications and neuromodulation. Um, so just briefly talking about trigeminal cervical complex, I did not want it to be a main topic here because um, it can become a boring topic for a lot of us because there's a lot of mechanisms, there's a lot of anatomy involved. But just the word itself, the complex itself, so trigeminal, which is one of the big nerves on our face. Cervical, again, is the neck, and it's a complex that's involved sending signals to our brain. So again, the main three things, the nerves, the neck, the brains, and of course, other studies showing that the proteins and the receptors that's involved, which we'll touch on briefly in the next few slides. So the main goal of migraine treatment or management is recognition and eliminations of the triggers or the exacerbating factors and personalizing preventive and acute. Or for some of you having chronic migraines, you know, when we mention acute, tends to mean abortive treatment options. I'm sorry that I must say migraine is a recurrent disorder, and as a result, it is possible that some people will have to manage it just like any other chronic medical conditions, focusing on long-term preventive medications and lifestyles modifications. For instance, just like people with diabetes, they have to both take medications and watch what they are consuming and engage with physical therapy. And here we discuss the medications used to abort or treat migraine attacks, which have not changed since 2012. Um, s- in terms of some of the available treatments, we have triptans. One of the most common ones are sumatriptans. Some of you might already know. Rizatriptans, almotriptans, um, and it's within the same family. And of course, over-the-counter non-steroidal anti-inflammatory medications is an option. And also um, anti-emetic or anti-nausea medications. It must be noted that severe nausea is associated with reduced effectiveness of some medications. And one study even showed that having persistent frequent nausea is a risk factor for progressions of migraines, suggesting that any effective treatment of nausea could improve both the short-term and the long-term outcomes of migraine therapy. Um, for some of you who got prescribed some of these medications for your acute treatment of migraines, some providers would also prescribe some anti-nausea medications to go along with it. Um, Different non-oral and oral preparations of triptans and the non-steroidal anti-inflammatory medications have been developed. Some are in nasal sprays, some are different injection preparations, some are just a patch that you can put on your skin, and some comes in powder form. The effectiveness might be improved because of the more faster onset of action of these medications than that of the existing medications. And in some patients who cannot really take medications by mouth, this other non-oral form of medication is really appreciated because they also help avoid the issues of impaired absorptions in our stomach during migraine attacks. Um, it is critical to note that taking medication early, during, or even when you start feeling that your migraine is starting to act up, is very important in optimizing and treating migraine. And this leads us to talk about preventive treatments of migraine. So we just talked about the acute treatments, and now we're going to talk about the preventive treatments. Similarly, medications used to treat migraines in terms for the prevention have not changed much since 2012. Um, Hence, there's no way that we can currently personalize which medication is best for which patients. The choice is often based on how much patient can tolerate the medications and whether the medication could potentially affect their other medical conditions. Um, so some of the preventive treatments that is out there includes beta blocker medication, which is a medications to block one of the receptors that tend to normally manipulate or induce our heart rate, whether slow it down or increase it. We have tricyclic antidepressants. We have anticonvulsants or anti-seizure medications like topiramate, or the brand is Topamax, and divalproex sodium. We have candesartan, which is another medication that we tend to use to treat blood pressure, but it is found um, as like a randomized control study found that candesartan is an effective preventive therapy. The study population itself is small, it's only 72 patients, but it was significant enough that a lot of clinicians use it as one of the tools that we use to prevent migraines. Um, the, and then after the least invasive that we just talked about, which is the oral medications, leading to the more invasive, which is injection. So we have Botox. The indication for Botox is only for chronic migraines, not other subtypes. And then we have the occipital nerve blocks. So just to touch on Botox briefly, um, if some of you who've had Botox before for migraines, you might notice that it's not just one injections at one location. It's multiple injections at different locations. So if you look at the bottom, uh, the figure with the face and the yellow dot or the orange dot. So the orange dot on the figure is the location where we target when we inject Botox. And it is based on a protocol. It's called the PREEMPT, PREEMPT protocol for Botox. You can search that up if you're interested. And it's basically targeting different muscles. And the mechanism itself, it's still not concretely known how it helps, but for some, it says that it helps with the nerve transmissions of the CGRP protein. So again, the Botox, so you have like once here between your eyes on the top of your nose. There's ones here on your the inner eyebrow area, a couple on the hairlines of your forehead, some here on like right above your ear area in the temple regions, several spots on the back of the ear and the back of the neck and also your shoulders. So in total, it's about 155 units, which about 5 units at each location. And this is typically done every 3 months or so. And for the occipital nerve blocks, um, it's most of the time it's two injections, one on the left and one on the right. Or if one side is worse than the other, you can just do one-sided if you think that you cannot tolerate the needle that well. Again, it's very least like minimally invasive. Uh, Here in our clinic, we tend to use ultrasound to help locate the nerves, but some providers can help locate the nerve just through the anatomy and feeling the location with their hands with some of the landmarks. So we inject and then we put the needle next to the nerve and inject either numbing medications by itself to help us diagnose, um, or numbing medications plus steroid to help both the diagnosis and the treatment of it, because the steroid would calm down those nerves and hopefully resetting it. Um, the nerve blocks itself tends to last for the durations of the medications, but the anti-inflammatory aspects can potentially last longer. Right. And then recently, um, there's 6 FDA approved anti-CGRP medications in the United States. CGRP is one of the proteins that we speculate with a lot of studies showing that it could potentially play a major role in the cause or the pathogenesis of migraines. The medications here, we have some that focus on the preventive aspects of migraines, while some are for the acute or the abortive aspects of migraines. So if you look at Amovic, Ajovy, Emgality, and Vyepti, those are for the preventive treatments of migraines. And Amovic, Ajovy, and Emgality are all injectable medications. Vyepti is an infusion through an intravenous line. Um, S- The common side effects of this injectable medication is injectable site irritations or reactions. The abortive or acute treatment medications are oral, so we have Nurtec here and Umbrelvy. Um, these two are approved by the FDA, and this all of these medications, although the approval is new, but it has been studied initially in the early 2000s. However, because of its liver toxicity with its use, it caused many drug companies to stop pursuing further studies until recently. And so these medications are more specialized, but I would like to emphasize that it doesn't have to be prescribed by a specialized clinician. Um, it can be started in the outpatient setting by the primary care provider if the clinicians are confident enough in their follow-up and choosing the right patient for the right medication. Medications include what we already discussed before, and most patients already tried many of the abortive and preventive medications before they actually come to us here at Stanford Pain, as we are a tertiary referral center. In fact, again, it is recommended that primary care provider refer their patients to specialists when migraines are not managed with first-line medications, such as the anti-inflammatory medications and the triptans. And again, some providers are well versed in managing migraines, that they are also comfortable prescribing many of the prophylactic medications to prevent migraine. And that also includes some of the anti-CGRP medications that was in the previous slides. Um, Here at Stanford Pain Clinics, we treat any chronic pain conditions from different angles. Um, we focus on medications. We focus on procedural interventions. We focus on brain psychology. We focus on physical therapy, and we also focus on research. Procedural interventions here at Stanford varies from less invasive, such as acupuncture, Botox, and the occipital nerve blocks that we mentioned earlier, to more invasive procedures such as a dorsal roots ganglion or a nerve roots block, or even radiofrequency neuromodulation. For pain psychology, we have a team of great pain psychologists, some of whom you already met before, who can offer non-pharmacological support and interventions. This is similarly with our pain physical therapists who can help provide rehabilitations for some of the persistent symptoms like vertigo or muscle pain. At Stanford, we have many research groups. Some of the studies that our clinics are involved with include studies that look at placing neurostimulator next to nerves that play significant roles in migraines, and also on part of the brains that is involved. I encourage all of you to ask about research studies that you might qualify for when you come here to Stanford for your care, as it would be a great opportunity for you to be a part of the future of medicine and innovations while benefiting from the innovation that Stanford has to offer. I know that we have only limited time to go over the topic that we have, but this concludes my presentation on migraines. I know that we went over a lot of things, although briefly, and hope as the goal is serving as an overview. And I hope that from this presentation, you gain some understandings of migraine as a complex medical condition. And too many patients, it is debilitating. However, the main take-home message is that it is an evolving field with a lot of new innovations that hopefully one day we have multiple medications and interventions to manage and treat migraine. Thank you again very much for your attention and for your time.